Hi there. I wanted to talk about the classification system. So in 2018, the American Academy of Periodontology and the European Federation of Periodontology worked to develop a classification system classifying periodontal disease and implant disease and conditions. So in this classification, they talked about what periodontal health is and gingival health. They have a gingivitis biofilm-induced category, which we've talked about, and they have the gingivitis with non-biofilm-induced, which we have talked about. Then they've talked about periodontitis, and they have 3 different categories for periodontitis: necrotizing periodontal diseases, periodontitis, and periodontitis as a manifestation of systemic diseases. So what they've excluded in this one is is differentiating between chronic and aggressive. So the thought is that those aren't different diseases. They have the same pathway. They are very similar, and sometimes it's actually hard to distinguish the two, especially as patients get older. So there's not a distinction with that, but they have included that in the system, and I'll explain a little bit later how they've made some inclusions for aggressive disease. So then we have this other section that's looking at other conditions that affect the periodontium when they affect the supporting structures, abscesses, mucogingival defects and conditions, traumatic occlusal forces, and tooth and prosthetic related factors. And then they've added a whole implant category. In the new classification papers, they describe what peri-implant health looks like, and they've have the classification for peri-implant mucositis, which is inflammation around the implant and no bone loss, and peri-implantitis, which is actually bone loss around implants, and then talk about peri-implant soft and hard tissue deficiencies. So that, in a nutshell, is the overview of the 2018 classification system. And we've talked about the gingival diseases. And then now the new part that I want to focus on today is talking about the staging and grading. So here is a table that's from the original paper, where you will find most of the information in this one table. And let's take a look. So in this classification, there are 4 stages. So stage 1 is actually periodontitis, and they're talking about clinical attachment or CALs at the site of greatest loss are 1 to 2 millimeters. Radiographic bone loss is less than 15%, and there is no loss of teeth due to periodontitis. And typically, patients in this category will have a maximum probe depth less than or equal to 4 millimeters, and mostly horizontal bone loss. Stage 2 is CALs 3 to 4 and bone that's still in the coronal third, but in a percentage a little more, 15 to 33%, and still no tooth loss due to periodontitis. The maximum probe depths here are less than or equal to 5 millimeters, and mostly horizontal bone loss will be present. So now you kind of want to think of there being a big difference really between stage 2 and 3. As we go to stage 3, we have greater than or equal to 5 millimeters for Cal. Radiographic bone loss is extending to the mid-third of the root and beyond. And at this point, patients may present with tooth loss due to periodontitis. And if they've had any tooth loss, they'll minimally be a stage 3. So if they'll be in this category if they've lost less than or equal to 4 teeth. Now, in this complexity row, a patient may bump up for any of these issues. A typical stage 3 will have probing depths equal than or greater than 6 millimeters, vertical bone loss greater than or equal to 3 millimeters, furcation involvement, class 2 or 3, and moderate ridge defects. Stage 4 is greater than or equal to 5, and same with the bone loss extending to mid-third or root or beyond. Here, if they've lost 5 or more teeth, it's a stage 4. And then in addition to the complexity, in addition to the stage 3 complexity, patients may have a need for complete rehab, masticatory dysfunction, secondary occlusal trauma, mobility, for example, that's greater than 2 or greater, severe ridge defects, bite collapse, which you may see as drifting or flaring of the teeth, and when there's less than 20 remaining teeth. So that's a stage 4. So now what I was talking about complexity, let's say you have a patient that's mostly in this category, but they have 5 millimeter probe depths. That means you will bump up the patient from a stage 1 to a stage 2 due to the complexity. Let's do another example. Let's say you have a patient that's stage 2, and then they have vertical bone loss or 6 millimeter probe depths. You would bump it up to a stage 3. So you can always bump up a category due to complexity. Okay. Now I want to focus on the last row, and basically every patient should be deemed one stage. Not everybody may describe the whole mouth in diagnostic terms, although they should. So we describe the whole patient, doing a periodontal diagnosis, describing all the areas of the mouth. Then we'll classify the patient with the staging. And then for those people who don't do that, they'll describe using stages. So now, the other part of this, see how it says the molar incisor pattern? That means when that patient that might be aggressive, that term, that diagnosis that's not used in the periodontal diagnosis, but you're still feeling like they're following that pattern, you're going to include that with the stage. So you could say stage 2 with molar incisor pattern, and that would imply the patient has that aggressive type. So it's out of the classification, but it's still included. Now, I also want to talk about this. I have it bigger on the next slide, but this is unique to this classification system. It's the interdental cal is detectable at greater than or equal to 2 non-adjacent teeth. So this is interproximal teeth have to be 2 different sites that aren't close to each other in order to get the stage. Now, this is very different from the former case type where you needed 30% of the mouth to get the stage. So this is much easier to get higher staging in a way than before. Now, where it's more difficult is on the buccal. So there's a separate rule for buccal sites. So the buccal cal needs to be greater than or equal to 3 millimeters with pocketing greater than 3. And that needs to be detectable in at least 2 sites. So basically, you're really looking at minimally of 2 sites to get the stage. So it might not be very representative of the whole mouth, but it describes the potential threat for the patient of further breakdown. So this just has it a little bit bigger so that you can have that in your notes. And so in this particular staging, where they're not only are they talking about percentages of bone, but also where it is on the root structure. So here's just a slide showing you a stage 1, where the bone loss is in the coronal third, less than 15, which is 15%, which is very, very small, right? And then we have stage 2, which is still in the coronal third, but it's 15 to 33%. Then we have stage 3 and 4, which is extending to the mid third of the root and beyond. So I've just kind of divided the tooth there so that you can see it chunked up here. Basically, you're dividing the tooth in thirds. So it's another way to look at bone loss. So now, in addition to the staging, there is a grading. So let's take a look at this table. So this implies grade A, which is a slow rate of progression of disease. And a grade B is a moderate rate of progression of disease. And grade C is a rapid rate of progression of disease. And the intention of this table is, and the purpose of classifying patients in this way is looking at the rate of disease as well as the inflammatory burden of the periodontal disease on the overall impact for the patient, as well as the systemic burden of the periodontitis, as well as the risk of the periodontitis or of the patient to break down in the future. Okay, so let's look at grade A, so which is a slow rate. So this is direct evidence, which can be difficult. So if you have a new patient, you're not going to be able to figure this out necessarily. If you have a patient of record that you've been seeing for years and years, you'll be able to determine this. So this might not be applicable to every situation. But this is, so no radiographic bone loss over 5 years. A grade B would be less than 2 millimeters over 5 years, and a grade C would be greater than 2 millimeters over 5 years. So if you're seeing over 2 millimeters of bone loss, that's considered a rapid rate of disease. So now percentage of bone loss divided by age. So that's when you take a look at where the bone should be and the apex, and then you calculate the percentage of bone loss, and then you take that number and you divide it by age. And if you have less than 0.25, it's considered A. And if the number is between 0.25 to 1, it's considered B. And grade C, if it's greater than 1. I'll go over an example of this in a minute. The other criteria that's important is case phenotype. And this is basically looking at the biofilm that's present and the amount of destruction and trying to see if it's proportionate. So in a grade A, this would be someone that has heavy biofilm deposits with low level of destruction. Grade B is about, the biofilm is about what you'd expect for the level of destruction based on the biofilm. Grade C is when the destruction exceeds your expectation given the amount of biofilm. And specific clinical patterns suggest periods of rapid, progressive, and early onset. Molar incisor pattern, lack of expected response to standard bacterial control therapies. So this is patient has good home care, but they're not responding well. This is that patient that you think has aggressive disease. You're going to grade them a C. Okay? So some allowances for that aggressive form of periodontal disease. So now we have our grade modifiers. These are the things that modify disease as well as risk factors, right? So the big ones are smoking and diabetes. We've been talking about this for a long time, and so much so that they influence disease so much that they are part of the new system. So a grade A, slow rate of progression, this is considered a non-smoker. If a patient smokes less than 10 cigarettes of the day, a day, they're minimally a B. Smoker with 10 more or greater than 10 cigarettes a day is a C. Now, if a patient no diagnosis of being a diabetic, they're an A. If they're diabetic with an A1C less than 7, they're a B, and A1C greater than 7 is a C. So that means a patient could fall in this category, but if their smoking or diabetic status bumps them up, you will go up to a C. If you have a diabetic with an A1C of a 9, it's automatically going here, okay? Now, this is taking a look at the risk of the systemic impact of periodontitis and the inflammatory burden that's expected from the perio. So this is looking at CRP levels. That C-reactive protein is the systemic marker of inflammation and infection in the body. And a patient less than 1 is an A, 1 to 3 is a B, a grade C is greater than 3. So some patients may not know this or have this collected yet, but hopefully soon patients will start knowing and getting this blood work done. Here is a category of biomarkers. This is for, sorry, I keep doing that. Future biomarkers that they're creating space for the future of different biomarkers that they feel they'll know more about soon. But right now there are no values there, so you don't have to worry about that. Okay, so that's the grading element for periodontitis. So now let's take a look at an example of this, because sometimes that bone loss divided by age, this feels like a random number, especially if you're not mathematically inclined, as I know I'm not. But once I started doing examples, it makes a little more sense. And basically what this is really looking at is the percentage of bone in relation to the age. So generally, if you have more bone loss than you are of age, then it's going to be a C. If you have less bone loss than your age, then you'll be perhaps an A or a B. So let's say a patient has 20% bone loss. So that's going to be a stage 2. So if they have 20% bone loss and the patient's 87, that is a lot less bone loss than their age. And if you do the math, that comes out to 0.22, which sure enough is less than 0.25. So if you just kind of think about that in your head, that probably makes sense, right? Then if you have a patient that's 47, has 20% bone loss, so it's certainly not as good as this, but it's not horrible. So you do the math, the bone loss divided by age, and that comes out to 0.42, which follows in this category. If you have 20% bone loss on an patient age is 17 years old, well, certainly that's a big deal, isn't it? So the bone loss is greater than the age. And when that happens, you'll have the number will always be greater than 1. So if you do the math, it comes to 1.17, which is a grade C. So if you just kind of thought about this, slight bone loss at age 17 isn't expected, and it's certainly happening at a rapid rate. The typical age of onset of perio is about 35. So certainly when folks are a lot younger than that, they're either having that aggressive form or having a rapid rate of disease. So that is the staging and the grading in a nutshell.